Let's get going with the Endocrine 5 warm-up quiz. First question, what's the difference between the following disorders? So schizotypal is a personality disorder with interpersonal awkwardness, odd thoughts, and odd appearance. Schizophrenia is a form of psychosis where you have delusions or hallucinations and maybe there's negative symptoms. And that's going to be going on for more than 6 months. That's an important point. Schizoaffective disorder is where you have those schizophrenia symptoms plus a mood disorder. Schizoid is another personality disorder where you have voluntary social withdrawal. No psychosis, but they don't want to be around other people. Maybe they go off and live by themselves in a log cabin in the woods. Schizophreniform disorder is where there are schizophrenia symptoms that last more than 1 month, but fewer than 6 months. And then if the symptoms last less than a month, we call that brief psychotic disorder. Next, what's the treatment for nephrogenic diabetes insipidus? So we use hydrochlorothiazide, which is a thiazide diuretic, and that's going to help the body concentrate the urine. Amiloride is a potassium-sparing diuretic that we use for treating diabetes insipidus that's caused by lithium toxicity because amiloride closes the sodium channels in the collecting tubules, which is how lithium gets into the cells through those sodium channels. And then you can also use indomethacin, which is basically going to reduce renal blood flow and correct diabetes insipidus in that way. Now, that's it for the warm-up. Now you're ready for the lecture.
In this video, we're going to cover hyperaldosteronism and adrenal insufficiency. So let me start by saying that a lot of hormones, and aldosterone included, work like thermostats, or chemostats actually, and their jobs are to keep certain other hormones or electrolytes in tight ranges using positive and negative feedback mechanisms. So parathyroid hormone does this with calcium, TSH does this with thyroid hormone, and aldosterone, the topic of this lecture, does this with sodium, potassium, and indirectly with water. You'll see what I mean here as we move along. So aldosterone is the main mineralocorticoid in our bodies. Its main job is to regulate levels of sodium and potassium, and it does this via a couple of key actions. It increases sodium reabsorption at the principal cells and collecting tubules of the kidney. And when sodium is reabsorbed, water follows the osmotic pressure. And aldosterone also regulates salt and water balance in the sweat glands and in the GI tract. So reabsorption of sodium and water are important actions of aldosterone. And due to the fluid volume that follows, this is going to raise the blood pressure. So aldosterone is one of the hormones that helps you maintain your blood pressure by keeping you from losing too much salt and water. Then another action is that aldosterone will increase potassium excretion, mainly in the kidneys. So aldosterone makes your kidneys hang on to sodium and dump potassium. So what regulates aldosterone secretion? Well, basically aldosterone is stimulated and suppressed by abnormalities in the electrolytes it's trying to regulate. So elevated potassium will stimulate aldosterone secretion, really in a surprisingly linear way. And then on the sodium side, both low sodium and decrease in water volume can stimulate aldosterone production. This is both direct through the sodium effect and indirect through the renin-angiotensin system. So angiotensin II also will increase aldosterone production by ramping up that enzyme aldosterone synthetase, which you heard about in the adrenal hormone synthesis lecture. Then conversely, high sodium can suppress aldosterone. So of course there are other factors that influence sodium and water balance in the body, like the amount of ADH, for example. And for a variety of other reasons, the system gets complicated fast. But fortunately, the pathology with the system is fairly straightforward, as I'll describe now. So let's start with situations where there's too much aldosterone production. This is called hyperaldosteronism. As with many hormone conditions, there can be primary or secondary hyperaldosteronism. So primary hyperaldosteronism comes from the end organ, the adrenal gland itself, and it's caused by either bilateral adrenal hyperplasia or an aldosterone-secreting adrenal tumor, also called Conn syndrome. And this results in hypertension because there's retention of salt and water. It causes hypokalemia because of dumping potassium in the urine, and it causes metabolic alkalosis in a couple of ways. So first, the low potassium stimulates urinary hydrogen loss via the kidney, and aldosterone itself has a direct stimulatory effect in the kidney as well. Second, the body is trying to balance out the low potassium in the blood by pumping intracellular potassium out of cells and into the blood, and this pump exchanges potassium for hydrogen. So as the cells pump potassium into the blood, they pump hydrogen out of the blood, and the blood becomes more alkaline. So whenever they give you a patient with the triad of hypertension, hypokalemia, and metabolic alkalosis, there should be an alarm that goes off in your head that says, alert, hyperaldosteronism. The other interesting lab finding is a low plasma renin because of negative feedback. So renin is intended to increase aldosterone, but is suppressed when aldosterone is high due to overproduction at the adrenal gland. The normal mechanism of regulation is that the kidneys produce renin in response to a physiologic stimulus, which leads to the generation of angiotensin II, which stimulates the adrenals to secrete aldosterone. So if there's high aldosterone, negative feedback will suppress the kidneys' production of renin. Therefore, renin levels will be low in patients with primary hyperaldosteronism. Now, secondary hyperaldosteronism is a different story. It comes about usually due to a systemic or local process that causes low intravascular volume at the kidney. And I'll give you more detail on causes in a minute. So when the kidneys perceive low intravascular volume, this results in aggressive activation of the renin-angiotensin-aldosterone system. So there's high plasma renin causing high aldosterone, and if this becomes pathological, it's secondary hyperaldosteronism. So at this level, there's nothing wrong with the adrenal glands themselves, they're just misinformed. Okay, so what disorders would cause the kidneys to perceive a low intravascular volume? Well, it could be due to renal artery stenosis, which is a narrowing in the renal artery that reduces renal perfusion. So when there's not much blood reaching the kidneys think the blood volume is low everywhere, and they respond by increasing renin output to increase the vascular volume. The kidneys could also perceive a low intravascular volume in congestive heart failure, where there's a low left ventricular ejection fraction, so there's poor renal perfusion, and the kidneys start producing more renin. And then low protein states like cirrhosis and nephrotic syndrome could both do it. So with low protein states, there isn't much circulating albumin or globulin, so there's low oncotic pressure and plasma doesn't stay in the vessels. It's going to be dragged out into the interstitium by the higher pressures and stay there. And then there's a compensatory rise in renin levels as the kidneys perceive that low intravascular volume, and the body's trying to respond appropriately to that by secreting more aldosterone and retaining sodium and water. So to treat primary hyperaldosteronism due to a single adenoma, the tumor needs to be identified and taken out. It sounds simple, and sometimes it is. However, if both adrenals are producing too much aldosterone due to bilateral hyperplasia, or a person can't tolerate surgery, or you can't find an adenoma, then you can also treat medically with an aldosterone antagonist such as spironolactone or eplerenone. These are both potassium-sparing diuretics that block the aldosterone receptor. Now, if you're finding yourself having trouble remembering what the actions of aldosterone are, you might find it helpful to remember that spironolactone is both a potassium-sparing diuretic and an aldosterone antagonist. So potassium-sparing diuretics cause the kidneys to hold on to potassium. So if the potassium-sparing diuretic that happens to be an aldosterone antagonist causes retention of potassium, it stands to reason that aldosterone causes loss of potassium. Therefore, hyperaldosteronism causes hypokalemia. And if aldosterone is the opposite of spironolactone, and spironolactone as a diuretic causes decreased blood pressure, then hyperaldosteronism will cause elevated blood pressure. So you can kind of reason out the signs of hyperaldosteronism if you can remember spironolactone as the treatment. But you should remember the signs of hyperaldosteronism anyway because of the triad: hypertension, hypokalemia, metabolic alkalosis. So we've talked about syndromes of adrenal excess. We talked about Cushing's syndrome and excess cortisol in the last video, and we're just finished talking about excess aldosterone. So now let's talk about a deficiency of adrenal hormones, or adrenal insufficiency. So there are 3 levels of regulation where adrenal insufficiency can occur: primary, secondary, or tertiary adrenal insufficiency. So the problem, respectively, is at the level of the adrenals, which is primary adrenal insufficiency, or at the pituitary, which is secondary, or at the hypothalamus, and that's tertiary. So let's start with primary adrenal insufficiency, which is sometimes called Addison's disease, or some people drop the S and call it Addison disease. Now, be careful with the terminology because not all forms of adrenal insufficiency are Addison's disease. Addison's disease is specifically primary adrenal insufficiency, where the problem is intrinsic to the adrenal cortex itself. The most common cause of primary adrenal insufficiency is autoimmune destruction of the adrenals. A good 80 to 90% of cases of primary adrenal insufficiency are caused by autoantibodies that attack the adrenal cortex and pretty much wipe it out. Then, less commonly, the adrenals could be destroyed by metastatic cancer or tuberculosis or bilateral hemorrhage. So when the adrenal cortex is destroyed, it can't make cortisol and it can't make aldosterone. So what problem does that cause? Well, we've said that both of these hormones are important for maintaining the blood pressure. So without cortisol upregulating the alpha-1 receptors in the vasculature, and without aldosterone maintaining sodium and water balance, the result is going to be hypotension. Because there isn't aldosterone to stimulate sodium reabsorption, there's going to be hyponatremia. And because potassium is not lost in the urine, there could be hyperkalemia too. And then another big problem these patients have is generalized fatigue, anorexia, and weight loss. This is kind of the opposite of Cushing's syndrome. These people aren't obese, they're kind of wasting away and kind of puny. And then another big clue to Addison's disease, or primary adrenal insufficiency, is skin hyperpigmentation, as we discussed in the pituitary lecture. So remember, all the excess ACTH can stimulate the MSH receptors and cause hyperpigmentation. So skin hyperpigmentation is only a feature of primary adrenal insufficiency, not secondary or tertiary adrenal insufficiency, because as we'll see in just a moment, secondary and tertiary adrenal insufficiency are caused by low ACTH. Now, one of the most famous Addison's disease patients in the last 100 years or so was John F. Kennedy. And JFK had this reputation for being super healthy with this year-round tan, but the truth is he wasn't tan, really. He had Addison's disease, and that may help you remember that Addison's disease is associated with hyperpigmentation. Another cause of primary adrenal insufficiency that you should know about is Waterhouse-Friderichsen syndrome. So this is an acute primary adrenal insufficiency due to adrenal hemorrhage, typically from severe meningococcal sepsis and DIC. Other bacteria can cause it too, like Pseudomonas or Strep pneumo, but Neisseria is really the classic one. So there's cardiovascular collapse and DIC, which leads to hemorrhage into the adrenals and acute adrenal insufficiency. So the hints here would be adrenal insufficiency in a patient with severe sepsis, and maybe a petechial rash or coagulopathy from the meningococcemia and DIC. Okay, one more comment about primary adrenal insufficiency and then we'll move on. So these patients are deficient in two hormone groups, cortisol and aldosterone, because the entire adrenal cortex is taken out. So when treating, these patients need medications for both these deficiencies. This would be one of the glucocorticoid medications, hydrocortisone, prednisone, or dexamethasone, and also a mineralocorticoid. This is usually fludrocortisone. And only patients with primary adrenal insufficiency need fludrocortisone, as we'll discuss in a minute. Okay, so now let's talk about secondary adrenal insufficiency. Remember, primary adrenal insufficiency is at the level of the adrenal gland. Secondary adrenal insufficiency is one level up from that, which is the pituitary. So in secondary adrenal insufficiency, the pituitary doesn't make ACTH. Therefore, the adrenals aren't stimulated to make glucocorticoids. But the adrenals do continue to make aldosterone, which is stimulated by renin, not ACTH. So these patients don't get as much really hyperkalemia or hypotension with secondary adrenal insufficiency. And since there are low levels of ACTH, they also don't get hyperpigmentation. So with secondary adrenal insufficiency, there's no hyperpigmentation, no hyperkalemia, and no hypotension. But you do see the weakness and malaise and weight loss. And then we need to talk about tertiary adrenal insufficiency, which is a very common cause of adrenal insufficiency. And this is interrupted CRH production from the hypothalamus, most commonly caused by abrupt withdrawal of long-term corticosteroids. So if you give exogenous steroids chronically, this suppresses the body's normal HPA axis. And if the patient is going to stop taking them, they have to be gradually tapered to give the axis a chance to recover. Otherwise, your patient can develop tertiary adrenal insufficiency. So what happens is that when the patient takes steroids long-term, it causes negative feedback and tells the hypothalamus that it doesn't need CRH, or corticotropin-releasing hormone. Without CRH, the pituitary doesn't make ACTH, and the adrenals don't make cortisol. So this is a problem at the level of the hypothalamus, tertiary adrenal insufficiency. So this patient with tertiary adrenal insufficiency has inadequate cortisol production, but he should still have some aldosterone production. So again, there's no hyperkalemia and no hypotension. The adrenal glands will still work in most cases if they get the proper stimulatory signals. So as long as you gradually wean a patient off of glucocorticoids, the hypothalamus has time to sense the lower glucocorticoid level and start producing CRH again. Okay, that's it for adrenal insufficiency. Now it's time for the end of session quiz. So answer the quiz questions and then we'll go over the answers together. All right, first question. What are the clinical manifestations of Addison's disease? Hypotension, hyponatremia, hyperkalemia, weakness, malaise, anorexia, and weight loss. And then we also said skin hyperpigmentation might be an important clue. And what is the cause of Addison's disease? It's most commonly autoimmune destruction of the adrenals, resulting in decreased production of aldosterone and cortisol. Next, a 30-year-old man is undergoing an evaluation for hypertension. He has a history of multiple episodes of hypokalemia. Laboratory studies show decreased serum potassium of 3 despite replacement and metabolic alkalosis. What is the most likely cause of hypertension in this patient? Primary hyperaldosteronism. Then let's go over a few rapid-fire facts. So the most common cause of primary hyperaldosteronism is bilateral adrenal hyperplasia in 60 to 70% of cases, followed by adrenal adenoma, which causes 30 to 40% of cases. The medical treatment for hyperaldosteronism is spironolactone or eplerenone. Adrenal disease associated with skin hyperpigmentation is Addison disease. We've kind of beaten that to death, so I hope it sticks in your mind. And hypertension, hypokalemia, and metabolic alkalosis is hyperaldosteronism or Conn syndrome. That's it for this one. I'll see you soon.